Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the May 2025 issue of Journal Chest. There's a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. This month in our asthma content area, we have a research letter that evaluates the accuracy and risk of harm of asthma-related content on TikTok, and a How I Do It review on the potential utility of the assessment of small airway dysfunction with oscillometry to define asthma control and future risk. Next is our chest infections content area. The serum anti-glycopeptolipid core IgA antibody test may have a role as a broad screening test for non-tuberculous mycobacterial pulmonary disease. In this issue, Choi and colleagues evaluate the accuracy of the level of serum IgA antibodies against the glycopeptolipid core in screening for NTM pulmonary disease in 282 patients from the prospective European bronchiectasis registry. Median antibody levels were 0.2 units per ml in those without NTM isolation or NTM pulmonary disease, 0.3 units per ml in those with NTM isolation who were felt not to have NTM pulmonary disease, and 1.5 units per ml in patients with NTM pulmonary disease. The AUC for NTM pulmonary disease was 0.86 and 0.816 for discrimination of patients with NTM pulmonary disease from those with NTM isolation alone and those with no NTM isolation or pulmonary disease. These findings suggest the anti-glycopeptolipid core IgA antibody could accurately screen for NTM pulmonary disease in patients with bronchiectasis. Completing this section is a How I Do It review that shares expert opinions for improving patient outcomes when managing cavitary coccidiomycosis. Our COPD content area is next. The joint effects of socioeconomic status and phenotypic frailty on the incidence of COPD is unclear. In this issue, Feng and colleagues describe a latent class analysis of over 396,000 UK Biobank participants without COPD at baseline, used to define the socioeconomic status of participants, and mediation and interaction analyses to explain the associations between socioeconomic status and frailty on COPD risk. Compared with high socioeconomic status or robust health, low socioeconomic status with a hazard ratio of 2.69 and frailty with a hazard ratio of 2.75 increased the risk of COPD. An additive interaction of low socioeconomic status and frailty with COPD incidence was noted. Frail individuals with low socioeconomic status had the highest risk of COPD, a hazard ratio of 7.85, compared to robust individuals with high socioeconomic status. These findings identify low socioeconomic status and frailty as independent synergistic risk factors for developing COPD. Also in this section is an epidemiologic study of dietary pattern, sputum DNA methylation, and lung health in people who ever smoked, and a chest review on the emerging role of alarmin-targeting biologics in the treatment of patients with COPD. Next is our critical care content area. It remains unclear whether using a higher flow nasal cannula rate provides better outcomes after extubation than commonly used flow rates of 30 to 50 liters per minute. In this issue, Ruan and colleagues present results of a randomized controlled trial of 180 patients designed to determine if a 60 liter per minute flow rate of high flow nasal cannula for post-extubation care results in different extubation outcomes than a 40 liter per minute flow rate. The primary outcome, a composite of reintubation or the use of non-invasive ventilation within 48 hours after extubation, occurred in 22.1% of those in the 40 liter per minute group and 16.9% in the 60 liter per minute group, which was a non-significant risk difference of 5.2%. Those in the 40 liter per minute group had a higher risk of escalation in respiratory support, which was the use of non-invasive ventilation or up-titration of the high-flow nasal cannula settings. These findings show that a high-flow nasal cannula flow rate of 60 liters per minute does not reduce reintubation or non-invasive ventilation use compared to a 40 liter per minute flow rate. Other original research published in this section includes a 2-article series from the Minnesota Critical Care Working Group on monitoring and coordinating statewide critical care surge response and in crisis conditions during the COVID-19 pandemic. A randomized placebo-controlled feasibility trial of melatonin low dose for prevention of delirium in critically ill patients, and a secondary analysis of the device trial that explored video versus direct laryngoscopy for tracheal intubation following cardiac arrest. Onto our diffuse lung disease content area. There has not been a comprehensive analysis of sarcoidosis mortality in U.S. veterans. In this issue, Seed Ahmed and colleagues report findings from a population-based retrospective cohort study of nearly 24,000 veterans diagnosed with sarcoidosis between 2004 and 2019. The study was designed to discover the trends in all-cause mortality among U.S. veterans with sarcoidosis and the influence of demographics in geographic variability. After adjustments, all-cause mortality increased annually by 4.7% and was 6.4% higher in Black than white veterans. Risk factors for increased all-cause mortality included older age, male sex, Black race, Northeast residence, and lower risk with other service branches. These findings identify a rise in mortality of veterans with sarcoidosis with potential influences of different environmental exposures and smaller racial disparities in impact of area deprivation than was seen in prior studies. Completing this section is an original research study that evaluates quantitative computed tomography analysis in rheumatoid arthritis-related ILD and a point-counterpoint debate on whether the PPF clinical practice guideline should be implemented into clinical practice. On to our education and clinical practice content area. Virtual reality is able to show the anatomy encountered during curvilinear EBUS from the perspective of the location of bronchoscopic tools. In this issue, New and colleagues report the results of a randomized crossover study of 68 fellows and residents from 3 institutions designed to determine if the use of a virtual reality anatomy trainer for teaching EBUS-associated anatomy improves procedural performance compared with traditional methods, including 2-dimensional pictures or a 3-dimensional model. All 3 learning methods improved EBUS performance after the first learning session. Learners spent more time with virtual reality, but improvement levels were similar. The virtual reality approach leveled the impact of baseline spatial reasoning and was preferred by 96% of the learners. The user experience with virtual reality was positive for focused anatomy learning, ease of use, acceptable realism, and tolerance, but ultrasound interpretation remained challenging. These findings suggest a virtual reality anatomy trainer is preferred by learners, helping improve procedural performance regardless of spatial reasoning ability. Also in this section is a research letter that explored the presence of lung pathology in free divers with a history of pulmonary barotrauma, and a How I Do It review of how to build a team of nurse practitioners and physician assistants and optimize their practice in the medical intensive care unit. Our pulmonary vascular content area is next. Little is known about the predictors and potential impact of epicardial adipose tissue in pulmonary arterial hypertension. In this issue, McCarthy and colleagues report findings from a retrospective cohort study of 221 patients with pulmonary arterial hypertension enrolled in the Penn Pulmonary Hypertension Registry. The study was designed to determine if epicardial adipose tissue is associated with estrogen levels, disease severity, and mortality in PAH. 43% of participants had connective tissue disease-associated PAH, and 35% had idiopathic or heritable PAH. Epicardial adipose tissue increased over time in 72% of participants. High epicardial adipose tissue volumes with a hazard ratio of 2.62 and greater accumulation of epicardial adipose tissue over time with a hazard ratio of 1.09 were independently associated with worse survival. Those with high epicardial adipose tissue volume had lower serum estrone and estradiol levels. These findings show that high epicardial adipose tissue and epicardial adipose tissue accumulation are associated with worse survival in patients with PAH and with lower estrogen levels. Completing this section is an analysis of the association of pulmonary hypertension with trastuzumab emtansine from the French PH Registry and World Health Organization Pharmacovigilance Database. In our sleep medicine content area this month, a pilot study of glossopharyngeal nerve stimulation to stabilize the lateral pharyngeal wall and ventilation in obstructive sleep apnea is published as a research letter. Next is our thoracic oncology content area. It is unclear whether disparities exist for follow-up of incidentally detected pulmonary lesions. In this issue, Abrahams and colleagues report findings from a retrospective cohort of nearly 33,000 patients within a large regional integrated healthcare system who had a pulmonary nodule identified on diagnostic CT scans between 2012 and 2016. This study was designed to determine if patients residing in more socioeconomically deprived neighborhoods have a reduced likelihood of adherence to guideline-recommended follow-up of incidentally detected pulmonary nodules. 49.6% of patients had follow-up imaging or other diagnostic procedures performed within the guideline-recommended timeframe. There was a 3% reduction in adherence to follow-up for patients residing in the most socioeconomically deprived neighborhood quartile. Smoking status, multimorbidity, and congestive heart failure were associated with decreased adherence. These findings suggest poor overall adherence to guideline-recommended pulmonary nodule follow-up, with worse adherence in the most socioeconomically deprived neighborhoods. Completing this section is a research letter that described a quality improvement initiative to verify eligibility for lung cancer screening via a text message intervention. I encourage you to read our Humanities in Chest Medicine section, where you will find a case-based discussion of shared decision-making in the intensive care unit with patients who speak a language of lesser diffusion, as well as our commentary series, where thoughtful pieces about the optimal care of multi-organ disease after lung transplantation and a medical educator scholar fellowship designed to build diverse medical educators are present. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the May issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.